Okay, so what I'm going to talk about is something I think most people in the audience have heard about, this COVID-19 pandemic and the vaccination efforts and everything, and especially how we could do our little contribution through data science and causal inference. So everybody here, I guess, knows about Clalit, but just a quick recap. It's almost 5 million members, community clinics, 8 general hospitals, and a few more that are dedicated to specific issues. Everything has been digitized for more than 20 years, which means that we have a lot of data. And Clalit Research Institute is responsible for turning all this data into actionable items. So that could be applied medical research, it could be analytics for stakeholders, and it could be predictive models for proactive medicine. Now, the way we usually work is through this internal triplet where we have the data scientist working with a clinician and an epidemiologist, and together they take one of these problems and tackle them and reach some conclusion or a model that we then deploy to production. This went on very pleasantly for several years, and then something happened in 2020. SARS-CoV-2 came, and there was a pandemic. And to make a long story short, we had a lot of things that we had to answer fast. So, for example, you have descriptive issues, a lot of questions, like what sector isn't getting tested? Or what cities? Where do we have more community spread, and so on? You have predictive questions that we had to answer even before the first cases came to Israel. For example, who will have severe COVID-19? Or weekly during the pandemic, what is going to be the hospital load for every one of our hospitals every week? So staff can get prepared, and there's a lot of infrastructure you have to deploy when the pandemic wave is going up. And then what we're going to concentrate on today is the vaccination effort. So this is a causal question. Basically, it means I'm doing something in the world, I'm giving it some cause, and I want to see the effect. And today we know that the vaccine worked. I'll reach at the end a few questions that we have today, but we know that the vaccination worked, but back then, we're in a very different situation. Back then is half a year ago, right? It's not that in the distant past, even though it feels quite in the past. So we were at the end of 2020. We had a very steep rise in cases, and at the same time, we had a very fast vaccination effort. So already, I think 10% of the population was vaccinated by 1 dose by the end of 2020. And you have questions here like, is 1 dose enough? Do we really need 2? And how can we answer those questions? Thing is, that's the first thing you need. I mean, as a data scientist, you know that the first thing you need is a lot of data. And that's something that we have, that's not a limitation, right? We have all the background medical information for all our members, and these are across the whole population in Israel. We have socio-demographic information. We have daily data on the cases and on the tests and hospitalizations and what happened during that hospitalization and whether they were vaccinated or not. And we have a lot of data, really the best quality of data, and we can simply plot these graphs and reach a conclusion very fast where we see that about 16 days after vaccination started, the positive test rate of the vaccinated population is going down. Now, this is a very nice graph, but of course, there's no way to know if it's correct. Right? This is the problem with crude statistics and causal inference. There's simply no way to know if this conclusion is correct. It might be exactly the opposite. And to understand why, you have to go a bit into causal graphs. So this is the very basic of causal graph theory, where you have an exposure. In this case, it's binary. It's usually easier to talk about binary, but it can be any type of exposure, any type of effect, that you're trying to introduce into the world. And you're looking at an outcome. In our case, the infection with SARS-CoV-2, is it a severe disease? What about death? So you have some outcome, and you want to know if this exposure changes somehow the ratio of the risks for the outcome, or the risk difference, or whatnot. And then you have some covariates that can interact with the exposure. For example, color of hair, age, I don't know what, but as long as they don't impact also the outcome, you don't really care about them. What you do care about is those confounders, things that interact both with the exposure and with the outcome. And this is the most important thing in causal inference, is to understand these confounders. So when we look at that graph that I showed you, I could claim that the decrease here is simply the first people that we vaccinated were the medical staff. And they take precautions, and that's why they have a lower positive test rate. So I have some interaction between the exposure, that's its preferential in health, in medical staff, and with the outcome, that medical staff are more careful than the rest of the population. So that's why I see this effect. I have to take that into account in my models. And okay, and maybe some of you remember this graph. It's just an example of the type of confounding that we had. We had a changing pandemic, and vaccination changed between the social economical status, so between the tiers of the SES, and between ages, and everything is kind of mixed together, and that's just some of the confounders. So once you have all this data, you have to kind of think, and this is something you really have to simply have. You need domain knowledge. Right? This is where domain knowledge is the most important, and that's why we have clinicians and epidemiologists in our group. And what are the potential confounders? Now, I think everybody in Israel can think of a few, like, well, I know that my neighbors are like that, and I'm like this, and that's why I got tested, and they didn't, and they took the vaccine, and maybe I delayed my vaccination. It's something that we all felt in real life, but have to find these generalizable things about the whole population and how to measure them. So here are the potential confounders that we recognize, and some of them are measured through several sub confounders, but this is basically the issues. So we have age. Age impacts whether you're vaccinated or not, and when, and the outcome. There was a difference. We know there's a difference in severe disease and mortality between different sex. Risk factors. We'd say, why would a risk factor, if I'm going to have severe COVID, impact my rate of infection? But we know that people with risk factors got vaccinated first, and they're also more careful, so they're also going to have less infections, maybe. Health vigilance and awareness. This is a very personal trait. When I feel bad, do I actually go to the doctor? When there's a new vaccine, do I actually take that vaccine? How do I control for that? Pregnancy, calendar time. Why is calendar time important? Because if I got vaccinated in the peak or before the peak, it's going to have a different effect on whether if I'm going to present the outcome, right? If the pandemic is spreading, then there's going to be more and more outcome, like positive infection. If it's going down, there's going to be less and less. So the calendar time is important. There was a difference between sectors, and inside sectors, we usually categorize into three, which is the general Jewish, Arab population, and ultra-Orthodox. These are the main sectors in the medical records. But it also goes down to the exact neighborhood and area of residence, which is highly correlated to the social economical status. And of course, nursing homes, health workers, and so on. So some of these confounders we controlled for, and some of them we removed to have a more represented, because I'll show in a minute how we controlled for them, and then it'll be easier to understand why we didn't, for example, take nursing homes and so on. Okay. So we understand our domain, we understand the data, we understand the confounders. now you have to start building your mechanics, like what is the measurement system you're going to use? And then you want to find a causal inference design that meets 3 basic criteria. The first one is exchangeability, which, if you think about it, also means that there's no unmeasured confounders. It means that I account for all things that impact both the exposure and the outcome. And it also means that if we switch between the treated and untreated, nothing will change in my estimation. Okay, I took care of everything that can impact the difference between the treated and untreated. It's untestable. This can only be implemented, like these confounders can only be found through domain knowledge, and there's no way to know that you took care of everything, but there are ways to feel more confident, and I'll touch that later. And the second thing is positivity, which is the actual ability to define the causal question, the causal estimation. If I try to measure the effect of the vaccine on 8-year-olds, there were no 8-year-olds that were vaccinated. The question is not defined. So I have to make sure that in my data, for every person that was vaccinated, there's somebody similar that was unvaccinated, that was not vaccinated, not unvaccinated, but that was not vaccinated for anything relevant. Okay, I don't care about the color of the hair. That's not a confounder. But for anything relevant for the vaccination, it has to be in both sides of the equation. And consistency, which in our case is a bit easier during this vaccination effort. There's no variation in the treatment. It's a well-defined treatment. Right? When I give somebody a vaccine, there's no, it's not that I gave some people a different vaccine and I don't know about that. Okay? The treatment is well-defined. So now that we need to find some measurement, some piece of like this modeling equipment that will take care of all of these demands and all of the confounding. And we choose a technique that's called matching, which is basically means that you take one person that was vaccinated and you find an exact twin as much as you can from your data, taking into consideration all the confounders. You find this exact twin that was not vaccinated yet. Why did we do that? There are much more fancier and even easier to implement techniques. The reason is that there's a lot of weight on the place you live and the day you were vaccinated. And it's very hard to build a model where you parameterize thousands of neighborhoods in Israel. So if you want to take into account that in the north of Ramat Gan, there's more infection than in the south of Ramat Gan in a specific day, you want to match 2 people, one from the vaccinated cohort and one from the not yet vaccinated cohort. You want to match them so you have an exact representation of every confounder. And it also enables you to feel that you take into account everything. You can feel this exchangeability through negative controls, and I'll talk about that in a minute. And finally, everybody at that time was used to seeing these graphs, these cumulative incidence graphs. And once you use matching, you can look at these cumulative incidence graphs where you ask, well, as days pass from the first vaccine, what is the incidence of the disease in each one? And then you look at the difference between the 2 lines and you say, well, from this point on, I can understand the difference in the risks if the 2 groups are equal in characteristics, not in quantity. So it sounds like we're finished, right? You look at the end of February, at the beginning of February, look at everybody that was vaccinated, everybody that was not vaccinated yet, and you simply match them with all these characteristics. And then, unfortunately, again, you're going to get a wrong answer. Why? Because when you match this person, okay, that was not vaccinated yet, he wasn't vaccinated until the beginning of February. There's some underlying characteristics that, whoops, press the button. Oh no, now you know what you have to do. Okay, so it's a bit strange, right? This person, why wasn't he vaccinated yet? All the other 70-year-olds were vaccinated. Why is he still not vaccinated? It introduces some confounding that it's very hard to take into account. I mean, did something happen in his neighborhood? Did something happen along the way that changed his behavior? Was he exposed and you don't know? It's hard to say. So the best way to approach is to try to emulate our best technique for clinical design. This is a randomized control trial. What you do, you take a cohort and you simply randomly allocate without even knowing who you give what. For one person you give a placebo, one person you give them the real vaccine, and you track them over time. We cannot do that, but we can try to emulate that. So we take somebody that was vaccinated, and we take somebody that was not vaccinated yet. So imagine that you gave this person a placebo here. And then you track them over time, and you have a certain amount of follow-up days, and then that person was vaccinated. And that's when you stop following this couple. So for this couple, up until this point, basically you're emulating an RCT. And this is very statistically powerful. You know that you're removing a lot of biases, selection bias, and so on, because you're simply emulating this randomization of controls. So then what you can do, you can introduce a rolling matching where every time that somebody is vaccinated, you take somebody that was not vaccinated by that point, and then you also capture some temporal bias and personal characteristics that these two people were not vaccinated until this day. So they're much more similar up to that day than somebody that was vaccinated early on. And you can do that, and it also enriches your data set quite a lot. Okay, so now we have our let's say, our apparatus. Okay, we have our microscope to measure everything. But how do you know that it's calibrated? Now, when you do experimental physics, that's my background, what you know is that in order to reach a conclusion about something that you're measuring, you have to calibrate your tools. And unfortunately, we cannot really be sure that we calibrated perfectly our tools. It's especially in terms of exchangeability. But we can use controls, and specifically a negative control outcome. The negative control outcome is something that we know is not impacted by the exposure. We should not see any effect, but it is impacted by all our confounders. So if we model the negative outcome and we measure it, and we see no effect, then we know that we took into account the confounders that might bias our estimation, but we modeled them accurately into our model, and then that's why we don't see any effect. Now, of course, it's not foolproof. It might be by chance that things are falling on top of each other in our negative control, and later on things are going to change, or maybe our model is very specific, captures one side of it, not the other, but it increases your confidence. It's a good control. And what we had here, like it is, that we have a very nice negative control, and that's the fact that the vaccine shouldn't have any impact in the first days. And the first up to 14, we usually took it up to 12 days, there should be no effect of the vaccine. So as long as we see some difference in this, in the first days, we know we have some confounding, some residual bias that we're not taking into account. So you calibrate your confounding and matching, and you find more and more features until things fall straight on top of each other, also in regards to the testing rates. And from that point on, you feel more confident about the rest. This was published in the New England. It was really a team effort, and a lot of people worked on this. And I think today we all can cite the results, right? It's 95% effectiveness, for infection, for severe disease. It also reduces death and so on. Also in subgroup analysis that was later published. That's great. So another question that everybody is wondering about, what about Delta? Right? Like, aren't we reliving January 2021, right? It feels like they're showing the same movie again. What about Delta? Is the vaccine effective? Why can't we simply use the same tools? Why is it so hard to answer it this time? Thing is that we're breaking all of our, we're not breaking, but it's hard to ensure the three basic criteria of causal inference. The first one is exchangeability. Anybody that was not vaccinated yet, why? I mean, is he even going to be tested once he feels bad? He's a very peculiar case. Positivity. How are you even going to find controls for when 90% of the 70-year-olds are vaccinated, and especially controls with risk factors? What about consistency? We're talking about waning. That means that we can't even really, it's very hard to even define the exposure. What does it mean to be vaccinated if we have waning? And the last thing is, remember that crude statistics can be completely misleading. And let's say all these, well, I plotted this against that and look what I saw. We know that it can be completely erroneous. And that's why currently we're really not sure what is the correct result, but we're trying to solve that. So thank you. We're also looking for data scientists, statisticians, analysts, epidemiologists, like everyone. And thank you.
Thank you very much.